Bismillah ar-Rahman ar-Rahim. Welcome in this meeting of Egyptian Society of Nephrology and Transplantation, CME chapter meetings. And this is the start of our new season in post-summer vacation. And we'll start to have a good and powerful start today by the lecture for Professor Mohamed Zaki. Professor Mohamed is the professor of nephrology and medicine in Mataraya National Urology and Nephrology Institute, and he is the dean of the institute in Ministry of Health, Egypt. He is currently the Secretary General of Egyptian Society of Nephrology and Transplantation and the Arab Society of Nephrology and Transplantation and the Africa ISN Committee Chair. He will speak today about plasma exchange in various kidney disease, and he will give us an important idea and general idea about the use of plasma exchange, the technique of plasma exchange, how to use plasma exchange and in different diseases, especially in his field of interest in kidney transplantation. So I will leave him the floor and come to you back after the discussion, which I expect to be a heavy and hot discussion, hot scientific discussion from the attendance of this meeting, especially as we have Professor Hisham al-Sayed, the president-elect of Egyptian Society with us now, and I'm to welcome him. Before I leave the floor to Professor Mohamed, I am to thank Dr. Hazem Abu Shusha, the fellow of Egyptian Society of Nephrology and nephrology consultant in Egypt and fellow of Egyptian Fellowship of Nephrology for all of his work in CME chapter and especially the coordinating this meeting. Please, Professor Mohamed, start your lecture, and I will come again for the discussion after your lecture. Start, please.
Thank you, Professor Yasser, for your kind introduction. It's my pleasure to meet you again in the CME recurring lectures of the Egyptian Society of Nephrology and Transplantation. This event that recurs every Wednesday at 9 p.m. Cairo time, and it became one of the pillars of the Egyptian Society of Nephrology and Transplantation, the educational limb of this prestigious society, which I have the honor to be the Secretary General of it, as well as being the Secretary General of the Arab Society of Nephrology and Transplantation and Africa Regional Board Chair and International Society of Nephrology Chair of the Transplantation Working Group. Well, this is the lecture. It's about updates in plasmapheresis, and this is my disclosure. Our agenda will contain definition, indications, mechanism, replacement solution, how to choose a plasma filter, complications and precautions, general orders, and total plasma exchange and COVID-19. Plasmapheresis, it's a total plasma exchange. They are synonyms, or TPE as abbreviation. It comes from the Greek word apheresis, which means taking away. It is the procedure in which the patient's plasma is separated and removed from the whole blood. The idea itself is not that new. Actually, it's a very ancient idea, as we all know about cupping, or in Arabic, al-hijama, in which there's hot bottles that are put on the body to, suck the blood into the skin. And a very ancient concept was by using what we call the medical leeches, or in Arabic, al-alaq al-tibbi, which is small worms that suck blood. They were put on the place where there is a wound or something to suck what they assumed as, a rotten blood, and they want to get rid of it. So the concept is old, but the first known use of plasmapheresis was introduced in 1914. It was very primitive also as well, yet the real plasmapheresis as we perform nowadays began in the 1950s. The removal or the removed plasma is replaced basically by one-on-one ratio with a replacement solution. There are some general indications. These are the general indications. Sorry, 1 second. The general indications. Among them is some famous indications like anti-GPM disease, TTP, cryoglobulinemia, hemolytic disease of the newborn, ITP, staph protein A adsorption, HIV-related syndrome, polyneuropathy, and hyperviscosity, TTP, myasthenia gravis crisis, Eaton-Lambert myasthenic syndrome, etc. These are some of the known indications that we all familiar with. Again, there are some indications according to the American Society for Apheresis in 2016 for therapeutic apheresis and cytopheresis procedures. We have some like acute liver failure where you use TPE but with a special filter, and age-related macular degeneration or dry macular degeneration, where there is a special form of plasmapheresis called rheopheresis, as we will mention later. This is another kind of apheresis. Also, in case of amyloidosis, especially systemic type, beta-2 microglobulin, where you can use columns to remove this, special columns, special filters to remove this substance. So indications in kidney transplantation, we have for treatment of renal disease or for prophylaxis of recurrence of original kidney disease like in FSGS or focal segmental glomerulosclerosis, if it was the primary original kidney disease, and for desensitization by high PRA or ABO incompatible transplantation. For non-rejection causes, you can use it for recurrent FSGS, for anti-GPM disease, and hemolytic uremic syndrome. While for rejection, it's a bit doubtful, especially in chronic antibody-mediated rejection. These are some of the indications, the percentages of the indications used in which we use plasmapheresis. You can see that 62% of all plasmapheresis performed worldwide are done for HUS, whether typical or atypical, and TTP. They constitute around 62%, and as we all know, they are interrelated diseases, so we categorize them all into one category. Other indication for humoral acute antibody-mediated rejection, ABO incompatible, and hypersensitized patients, they constitute around 12%. And the remaining almost 25% are for other indications like Goodpasture syndrome, FSGS, cryoglobulinemia, ANCA-related vasculopathies, etc. So, sorry because I'm broadcasting from the mobile, so it's a bit tricky. Yes. What is the mechanism of action of plasmapheresis? Some possible mechanisms of action include removal of abnormal circulating factor like antibody in case like anti-GBM disease, myasthenia crisis, Guillain-Barré syndrome, monoclonal protein like Waldenstrom, macroglobulinemia, and myeloma proteins, circulating immune complexes like in cryoglobulin and lupus, alloantibody, example, RH alloimmunization in pregnancy, and toxic factors like TTP, HUS, and FSGS. Another speculated mechanism of action is the replenishment of a specific plasma factor like thrombotic thrombocytopenic purpura, or other effects on immune system like improvement in function of reticuloendothelial system, removal of inflammatory mediators like cytokines, complement, and shift in antibody antigen to move to more soluble forms of immune complexes. Also, stimulation of lymphocyte clones to enhance cytotoxic therapy. We talk about components of blood. We know that blood has cells, blood cells, whether red blood corpuscles, white blood corpuscles, white blood cells, or platelets, and all those cells are circulating within the liquid form of blood, which is the plasma. Plasma has almost 90 to 92% of its constituents as water, and almost 7% proteins, and from 2 to 3% other things like fats, carbohydrates, electrolytes, gases, and chemical messengers. And this is how the blood is formulated, and this is the target of this therapy, is the plasma of the blood. The distribution volume of immunoglobulins, and this is a very important subject we need to talk about. Why we need plasma exchange? Why we don't just set for ordinary dialysis or maybe high flux dialysis or so? Because as you can see here, that for, sorry again, as you can see here, the small molecules like urea and creatinine with small molecular weight are easily to be removed by conventional hemodialysis by diffusion, by simple diffusion. Also, they definitely can be removed by hemofiltration, by convective clearance also. But middle molecules with middle molecular weight, they cannot pass through the pores of the conventional dialysis or the low flux dialysis. So we need a bigger pores to allow for larger volume to pass through. Example, beta-2 microglobulins, kappa light chains, lambda light chains, etc. So here we will need the high flux filters or hemofiltration. Very large molecules, example, immunoglobulin M, which is 950,000 Dalton, or IgG, which is 160,000 Dalton or 160 kilodalton, and albumin, which is 66 kilodalton or 66,000 Dalton. They are very large. They will not pass unless by therapeutic plasma exchange. So, and also lipoproteins, which constitute or the molecular the molecular weight of them is almost 1 million Dalton or 130 kilodalton. They all have this very large molecule which would not pass unless by the TPE filter or the total plasma exchange. We have two types of total plasma exchange. We can perform it via two mechanisms, whether by the centrifugation technique or by the plasma filtration technique. And you can see in this illustration the idea of the centrifugation. There is spinning bowl. This bowl, the blood is driven from the patient into this bowl, which spins in very rapid cycles or spins. And at each level of spinning, one of the blood constituents just being removed or filtered due to the centrifugation power, which is compatible with the blood or the molecular weight of each of these cells. So at certain level, you can see that red blood cells are separated, white blood cells separated, platelets separated, albumin, etc. And then the supernatant or the effluent that is being separated is removed, and the blood cells are whether be reintroduced to the patient or also this is the technique where they separate the blood constituents for those who donated their blood into the different blood components for donation, red blood cells, cryoglobulins, plasma, etc. It's the same technique, and usually it's done by the blood bank more than by the nephrologist. But of course, we as nephrologists can use this, and many of us in our departments have such device also for usage. The other technique is the plasma filtration technique, where the blood is taken. It's the same concept as dialysis. The blood is taken from the patient and it goes into the filter. And this filter is, as we mentioned, is a special filter where the plasma is filtered into the effluent bag, and the remaining blood cells are taken and reintroduced with the replacement fluid into the patient again. And as we will see that in all indications, replacement fluid is by 5% albumin, except in one or two indications, namely the TTP and HUS. Other than this, it's all by albumin. There is no role for plasma as replacement fluid unless in this very limited indications. So this is the idea of the technique of both. And here you can see the evolution of the machines. This the machine on the upper left-hand side is a machine from Glasgow. It was invented in 1973. In 1982, University of California, South also invented this machine. And in 83, they reinvented another machine to reach now the machines that we use now. On the left side, this is the centrifuge machine, and on the right side, this is the plasma filter or plasma exchange machine, or the conventional one that most of us use. Or you can use the same dialysis machine with the TPE filter in other cases, with a replacement fluid to be replaced individually. But of course, to return in the same time to the patient with the blood constituents, but by another pump if you don't have the designated machine for plasma exchange. So this is also to continue the mechanism of action. You can see on the left side, filtration. In this case, there is simple filtration technique by which the pore size and charge differentiate filtered plasma compounds from blood. You can see that the big components, like the big red blood corpuscle that you can see, it cannot pass, while other components, they can pass. And then the blood components are taken while the plasma is separated alone. While centrifugation, as we said, as you can see here, by gravity and density differentiation, you have different levels. The first, the supernatant, is the plasma compound, then platelets because they are smaller, then leukocytes and stem cells, and the large erythrocytes are in the basal part. There is something called double filtration. By double filtration, we mean that we can use another filtration cycle after the first one, because some of the constituents that just pass through the pores that we don't want to lose them, they go into another cycle with a filter with smaller size, by which it separates these items and put them back into the returning blood, and then the effluent is taken to get rid of. And you can see this in the lower drawing. I will excuse now. I just arrived home. If you give me 5 minutes, I will just log in through my laptop. That would be better. I'll just go in and log in, and I'll join you maybe before 5 minutes. Sorry.
حازم اتفضل.
Yes. So we this is the last slide we were standing on. We will just continue to the next one. So what is rheopheresis? We mentioned rheopheresis a while ago as one of the specific indications. It is a process to change the viscosity of blood by filtering blood to remove some components such as fibrinogen, alpha-2 microglobulin, von Willebrand factor, LDL cholesterol, and immunoglobulin M. And it's, as we said, it is mainly for the treatment of the dry age-related macular degeneration. Again, here the concept is easy. There is a plasma separator. This plasma separator, the blood goes through it, just as the conventional TPE we mentioned a few minutes ago. And then the cells are taken and the effluent is put again into the rheofilter. Again, there is some changes in the pores of the filter, the size of the pore, and the electricity or the electric charging of the fibers. This is a special plasma filter for such condition, and this is to be filtered, and then it will be taken back. The filtered plasma is taken back to the blood. So here, in such case, we don't need to do replacement, because actually the plasma is given back to the patient. It's not filtered and removed. We remove only the very large molecules, as we said, fibrinogen, alpha-2 microglobulins, von Willebrand, etc. So this is very special type of plasma exchange. So there is a very peculiar one second, characteristic for plasma exchange. It is that you don't have to have a blood speed. I'm talking of course about the using the machine, not the centrifuge. Some would assume that if we made the pump speed higher, this might increase the filtration. Actually, it is you can reach the maximum filtration rate at a relatively low transmembrane pressure of approximately around 40 millimeter mercury, as shown in this arrow. So you don't have to go for a higher TMP. This is the maximum that you need. After that, it is useless, and sometimes it is hazardous. That's why you don't have to have a very high TMP or filtration rate. So to compare between the plasma, the membrane plasma separator and the centrifugation, The advantages of the centrifugation: it is more efficient in removal of all plasma components, can be adopted for cytopheresis, as we mentioned. In blood banks, they use it to separate the blood cells or the blood components into different types to use them as for donation later on. And there is no need for central venous catheter, because you just need minimal blood volume or pressure, not as in the machine, as it is a dialysis machine at the end of the day. So you need higher blood flow, and that's why if the patient does not have an AV fistula, for instance, then you should go for a central venous catheter. But what is the advantages of mechanism or of membrane plasma separation? There is no loss of cellular elements, because there, as you've seen, the bowel, when it spins, sometimes you may lose some of these constituents. There is no requirement for citrate, because in the other type, the centrifugation type, you have to give citrate sometimes in massive amounts, and we all know that there are hazards for citrate infusion, and can be adopted for cascade filtration, as we shown before in rheopheresis or the double filtration. This is what they call cascade, on 2 or 3 sometimes levels of filtration. And the disadvantages of centrifugation is exactly the different. There is loss of cellular elements, usage of anticoagulation, especially the citrate, it might cause hypocalcemia, arrhythmia, hypotension, and it is expensive relatively compared to the other type. While the other type will require a central venous catheter, and it requires high blood flow between 100 and 150 milliliter per minute, and there is limited plasma pheresis. You cannot go for larger volumes like what you do with the centrifugation type. The relation between plasma volume removed and the concentration of substance. Also, you may assume that the more we remove and replace, the more we get to get rid of more substances. But actually, this is a bit not true, because as you can see, if you removed only 0.5% of the plasma volume removed, you will only remove around 39% of the desired substance for removal. If you removed 1 plasma volume, you will remove almost 63%. What about if we remove 1.5? The number will increase to 78%. And if you remove 2, you will go to up to 86%. So you can see that the difference is not that huge, and it does not justify the hazards of removing more volume and the expenses for removing more volume. So most of the replacements in most of the indications use 1 plasma volume. Sometimes we may go to up 1.5, and very rare to go to 2, but usually in 90% of the cases, you will set for 1 plasma volume for exchange, and this is more than enough. As you can see, the most of the desired substance to be removed will be removed within the 1 plasma volume. So this is very important. There is what we call immune adsorption, and it has some superior indications versus plasmapheresis. It's in antibody reduction therapy. Immune adsorption have the advantage of the high selectivity of immune adsorption versus plasmapheresis. High selectivity facilitates therapy schemes involving more than 1 treatment on each consecutive day, since only small amounts of essential plasma components such as albumin are removed. And in the case of other extracorporeal procedures such as plasma exchange, this is difficult to achieve. We cannot be very specific. It's a crude method, not like the immune adsorption, which is rather specific. There is what we call reaccumulation, and this will justify why in the most of the protocols, the first 3 plasma exchange sessions are done on 3 successive days, and then we can go every other day later. Because as you can see on this diagram, there is rapid accumulation after first session, and this reaccumulation becomes a bit lower after second session, and then it almost becomes equal in the after third session, and it goes this way. Even if you went daily or every other day, the rate of accumulation is much lower. So that's why most of the protocols signify the first 3 sessions to be done daily and then every other day later on. Replacement solution, usually we replace by albumin, human albumin. It has no risk of hepatitis. It is stored at room temperature. You don't need to have special refrigerators. Allergic reactions are less than that of the plasma, and there is no ABO matching, and depletes inflammation mediators. While the disadvantages, it's very expensive, of course, and there's no coagulation factors transferred with it, and there is no immunoglobulins. While fresh frozen plasma, the advantage is that you can, there is some transfusion of coagulation factors with it. There's some immunoglobulins transferred and complement as well. So if the patient is in need or immunocompromised, that might be of effect, of benefit if he's in the risk of infection. While the disadvantage is that it carries the risk of hepatitis or even HIV or any blood-borne infection. It has much more allergic reactions. After all, it is blood with all the hazards of incompatible blood transfusion, etc. So that's why it necessitates ABO matching, and it must be worn because it comes frozen, and hemolytic reactions are very common if there is ABO incompatibility. So specific indications for fresh frozen plasma, as I mentioned, because all other indications goes with albumin. It is indicated in TTP and HUS, pre-existing defect in hemostasis, risk of choline esterase depletion, and when the fibrinogen level is low, less than 125 milligram per deciliter. Practically speaking, on our scope as nephrologists, we face mainly TTP and HUS as indication for plasma replacement. How to choose a plasma filter? It should be, or it should have a better sieving coefficient, a better hemocompatibility, less hemolysis, less platelet loss, and more biocompatible surfaces and less TMP values. And of course, we have Professor Hisham Said. He's the best one to talk about filters. He's one of the pioneers in this field. He developed filters under his name. So if anyone wants to ask specifically about this point, you may ask in the discussion, Dr. Hisham, he can elaborate more in this. This is the two types we have. We have the 0.6 and 0.3 surface area, square meters. There's no much differences between them. Usually the difference is in the amount of blood filling the volume of this filter. Usually the 0.3 requires almost 36 milliliter versus the 0.6, which requires almost 70. Other than this, there is no much differences between both. Complications of plasmapheresis. Some related to vascular access like hematoma, pneumothorax, retroperitoneal bleeding. Some related to anticoagulation like bleeding, especially with heparin, hypocalcemic symptoms with citrate, arrhythmias, hypertension, numbness and tingling of extremities, and metabolic alkalosis from citrate. And some related to the procedure itself, like hypotension from externalization of blood in the extracorporeal circuit, like any other case of dialysis, if the blood pressure was low from the beginning. Hypotension due to decreased intravascular oncotic pressure because we remove the albumin. And bleeding from reduction in plasma levels of coagulation factors, edema formation due to decreased intravascular oncotic pressure, and loss of cellular elements like platelets. Ethylene oxide associated hypersensitivity reactions in case where there was some filters being sterilized by ethylene oxide. I think this is no longer, the case. Most are now steam sterilized. This is the related to vascular, as I mentioned, anticoagulation, and to procedure. Precautions if for hypocalcemia, prophylactic infusion of 10% calcium chloride during treatment, hemorrhage, 2 units of fresh frozen plasma at the end of the session may be used. Thrombocytopenia, consider membrane plasma separation. Volume-related hypotension, consider continuous flow separation with matched input and output. Infection post-apheresis, hypokalemia. Infection post-apheresis, use infusion of intravenous immunoglobulin 100 or 400 milligram per kg. Hypokalemia, ensure a potassium concentration of 4 millimole in the replacement solution, and membrane biocompatibility, change membrane or consider centrifugal method of plasma separation. Hypothermia, warm replacement fluids. Sensitivity to replacement fluids, consider diagnostic evaluation, anti-IgA antibody, anti-ethylene oxide antibody, anti-human serum albumin antibody, endotoxin assay, and bacterial cultures of replacement fluid, etc. And consider using starch-based fluids. Pre-medications regimens for sensitized individuals. You may give prednisolone 50 milligram orally, 13 hours, and then 7 hours, and then 1 hour before treatment, or diphenhydramine 50 milligram orally, 1 hour before treatment, and ephedrine 25 milligram orally, 1 hour before treatment. General orders for plasmapheresis: when you write the order for the treating nurse, calculate the plasma volume. The best and the easiest way to calculate plasma volume is to multiply the weight of the patient into 40. So if the patient weighs maybe 70 kilograms multiplied by 40, then you're talking about almost 2,800 milliliters or 2.8 liters, or somewhere between 2.5 to 3 liters. This is approximately the plasma volume, the one plasma volume for such patient. When feasible, measure the plasma level of the substance targeted for removal, if like an anti-GBM antibody, acetylcholine receptor antibody, cryoglobulins, etc. Space treatments approximately 24 hours apart. This is variable. We mentioned that usually in the first 3 days, we do every day and then every other day later. For heparin anticoagulation, low bleeding risk patient can give heparin 50 international unit per kilogram initially, then 1,000 international unit per hour. Target ACT is 180 to 220 seconds. If the ACT is less than 3 minutes, increase the infusion rate by 500 international unit per hour. If the ACT is more than 4 minutes, discontinue heparin infusion. Stop heparin about 30 minutes prior to the end of the procedure. For citrate anticoagulation, use ACD-A at 1 to 15 to 1 to 25 dilution with blood. Use calcium infusion if necessary. Cardiac monitoring. Administer scheduled medications only at the end of the session. Let's say the patient has an antihypertensive medication or oral hypoglycemic or whatever. You give it after the medication ends. After the procedure ends, not in the middle of the procedure, because most probably this will be removed during the procedure. Catheter care as per routine in any dialysis catheter. These are some of the regimens for plasma exchange. I will not go through it for the time's sake, but the general idea, as I mentioned, is that most of the cases usually go between 7 to 10 days, sometimes up to 14. Usually the patient replacement is by human albumin, and usually you remove one plasma volume, except in such cases where you may use the the fresh frozen plasma for replacement in the indications I mentioned before. These are some of the indications. So, efficacy of rituximab and plasmapheresis in an adult patient with anti-factor H autoantibody associated hemolytic uremic syndrome. This is a study. And plasma exchange for the management of catastrophic antiphospholipid syndrome, importance of the type of fluid replacement. Plasma exchange in such case in the catastrophic antiphospholipid syndrome is a life-saving procedure. In patients with catastrophic antiphospholipid syndrome, TPE is strongly indicated with urgency starting في أول 12 ساعة within the first 12 hours after signaling to apheresis unit. You should not hesitate or delay intervention. Session frequency is daily in the first 3 days, then it is tapered initially 3 sessions weekly according to the clinical condition and finally stopped when remission of thromboembolic disorder is obtained. At the time, the INR range should be 2.5 to 3.5. As a replacement fluid, 4% human albumin solution, also in the presence of microangiopathy, is recommended at least until ADAM TS13 activities can routinely and promptly be determined. This is the scheme for catastrophic antiphospholipid syndrome, which is one of the urgent indications or the emergency indications for plasma exchange. For this, I thank you so much, and I will stop here and go back to the chairperson and the moderators to start moderating the questions. Thank you for listening and waiting for your questions. Thank you.
Thank you, Professor Salah, for this very illustrative lecture about plasma exchange in kidney disease. You illustrated the technique in a very attractive and simple way, how to initiate plasma exchange, how to prescribe plasma exchange, a method of plasma exchange, whether centrifuge or membrane plasma exchange, and different points of plasma exchange, including machine, including anticoagulation, including replacement fluids, including frequency and blood volume calculation, and illustrated many theoretical points about our practice, including why do we use the separated day after day plasma exchange. You illustrated clearly the rebound phenomena and that ends the concentration of IgG by the end of 6 days. So we average use 6 sessions spaced to 1 day for a rebound, and average 6, the concentration reaches nearly its end of the removed molecule. And also illustrated in some diseases how to use plasma exchange and what are the indications of plasma exchange in some diseases, such as especially catastrophic antiphospholipid, anti-H factor H, and left other indications, broad indications, as it will take a separate lecture for broad indications of kidney disease, but gave a general idea about its use. Also, what replacement fluids and when to use this replacement fluid in what diseases. You stressed on that we use plasma, especially in cases of TTP, and thrombotic cytopenic purpura and microangiopathic states. They are specially indicated in this part. Also, various techniques of plasma exchange and therapeutic plasma exchange, including rheopheresis, including immune absorption, and including cascade filtration apheresis. And this was illustrated by you and touched these important techniques as not solely the technique of therapeutic plasma exchange, but also many other techniques that can be used. We have many questions on the chat, but before questions, Professor Hisham, do you have a comment, please?
Thank you very much, Professor Mohamed Salah. It's very informative. Yes, we are in need in more details for plasma exchange, maybe a series of that, in particularly for each disease. Just highlighting for who are attending this meeting, when you start plasmapheresis, you have to start urgent, as you perfectly mentioned. Don't wait, especially in some selected diseases like anti-GPM, catastrophic antiphospholipid syndrome, and for sure, complement mediated or TTP until ADAM TS13. Just I add to the list you mentioned for plasma, if your patient with diffuse alveolar hemorrhage with hypoxemia, the substitution should be preferred with plasma beside TTP. So this is an adding indications for plasma infusion or substitution to the list you mentioned. And thanks again, and we'll continue for the discussion with questions.
Thank you, Professor Hisham. If you have some questions on the chat, I don't know why all questions are by the phone names. Why not write your names, please? Is frequency of plasmapheresis difference according to the disease? What is the limit frequency in every disease need at from Dr. Masoud? I think free. Dr. Mohamed.
Yeah. Well, the frequency differs, of course, according to the indication. If you want me to show you, we had this schedule, but I had to run through it a bit fast because of the time. But there are many indications, and each of them has a certain schedule. As you can see here, for HUS, it's 7 to 10 days. For other indications like FSGS, it's for 10 days, cryo for 7 to 10. For anti-glomerular basement membrane, it's up to 14. So there are some differences. Usually, if you don't have a response, you continue on the technique unless you have complications started. When you have complications, you have to stop, even if you did not achieve. I can add some other indications, like in desensitization protocols, what we usually do is to perform 6 to 8 exchanges per cycle, and we call it cycle, and we see how much reduction in the panel reactive antibody level of this patient, or the antibody or the donor specific antibody level for this patient. And then if the patient's still in need, we can go for another cycle, maybe another cycle after a while, and so on. So according to the indication, unless you have complications that started, which warrants the stoppage of the technique. So you may replace or continue to do the TPE, the plasma exchange, till you get the response. Many of us, the most important indication or the most famous indication that we all probably seen is the Guillain-Barré syndrome, and especially during corona level. As you can remember, there was you may go on doing this sessions unduly till the patient have full recovery. Sometimes the patient recovers after few sessions, 4 or 5 sessions, and you stop at this point. And some patients, we kept on doing this for them for like maybe 12, 14, or even more sessions. In TTP also, some of the patients respond very easily, and some of them, and very rapidly, and some of them might need up to 30 sessions of plasma exchange till you have the response, monitored by platelet count. So each drug, each disease has conventional period and conventional number of sessions, but the session is modifiable according to the response and to the complications. Thank you.
Thank you. Exactly. Yes, Professor Salah. It depends upon the disease and depends upon monitoring and response of the patient, and also substance removed. For some diseases such as Waldenström, for example, we are removing IgM, and we need no more than 1 or 2 sessions to get a response. And as you said, in this, some diseases such as TTP, we continue for a long time, governed by platelet count, LDH, and the clinical response, and the anemia, etc. Another question: what is the long-term side effect of plasmapheresis? And you are to specify how long. Are you asking 1 month, years, 5 years? But he is asking about long-term side effects of plasma exchange.
I don't think that the nomenclature is very correct for long-term. I wouldn't say it's a long-term complication. It's just like in dialysis. You have a complication on the spot you have to deal with. If you mean by long-term that the patient had cardiac problem maybe, or arrested during the session and have myocardial infarction or stroke or whatever, this might be a long-term. But usually the complications that are very related to the procedure is usually complications that you have to deal with on the spot. The patient becomes hypotensive. You stop or you reduce the filtration rate. The patient is using anticoagulation like citrate. You give the antidote. The patient is having a reaction from whether the albumin or the fresh frozen plasma. You stop the infusion and you give antihistaminics and steroids, etc. So the terminology of long-term complications, because the procedure itself is not a long-term procedure like dialysis. You cannot stay on plasma exchange for 10 years or 20 years like in dialysis. You do it for a very limited time. At the end of the day, whatever the time is, it's very limited. Even in some indications that are recurring, like in FSGS recurrence post-transplant, and one of the protocols which were depending on the performing the TTP after transplantation monthly for 1 year. At the end of the day, you'll reach only 12 sessions, and there is a month separation between each session. So the terminology of long-term complications is not very descriptive, if you know what I mean. I would say the complications or the remote complications usually are not very specific to the procedure. They are specific to the complications, that the general complications that might happen with anyone in any dialysis or extracorporeal circulation.
Thank you. Exactly. It is an acute procedure, and all complications are acute complications mostly, and not a long-term effect, as you said, not related to the procedure itself, related to the other factors which are common for extracorporeal treatment, such as anticoagulation, such as central venous catheter. If the questions is directed towards mortality, or a difference in mortality, long-term mortality, it is related to the disease, will be related to the disease with the use of plasma exchange or not using the plasma exchange, will be specific for each disease. Again, not to the procedure itself, if this is what is behind this question. Thank you for your response. We have two questions about the role in atypical HUS, one from Dr. Arola Osman. Welcome, Dr. Arola. She is asking about in non-complement anti-endothelial HUS and anti-CFH. Should I use plasma as a constituent, or can use albumin in addition?
No,
And the other question is the role, of course, in a typical HUS.
This is one of the very minimal indications or very little indications for usage of fresh frozen plasma. In such case, it's better to use fresh frozen plasma rather than albumin. And this is one of the very few indications, as I mentioned, and Dr. Hisham elaborated, for usage of fresh frozen plasma as a replacement fluid. The other part is what's the role? It's substance removal. You remove the complement immune complex, including complement and other factors, by removing them, and you replace new plasma. So you're getting rid of the substance, or the hazardous substance, or the causative substance from the plasma.
But I think the role in HUS is not that clear as for TTP, for example.
Yeah, but this is the presumed role. There are, of course, some other speculations, but usually this is the role. Dr. Arola is saying why regarding what why what?
Why to use specific fresh frozen plasma? Her question about the use of fresh frozen plasma, not albumin.
This is the indication. This is one of the few indications for fresh frozen plasma. I can show you also if you want from the schedule here. It is one of the very minimal indications for using such.
If you allowed me just to add for this question,
اتفضل يا دكتور.
the principle of plasma substitution in TTP is for substitution of atom TS13 itself.
Yes.
That's why we are 100% we have to use fresh frozen plasma.
Yes.
But if you go for complement factor H antibody, if you diagnose that, you don't have to do with all of fresh frozen plasma, but you may have some of them of fresh frozen plasma because of replenish of coagulation factors.
Yes.
So it's a debatable part for complement factor H. In general, atypical HUS or complement-mediated HUS in the rule of plasmapheresis, unless complement factor H antibodies, which has a strong rule here. But I agree that you can do it with albumin because there is no atom TS13 deficiency.
Generally, plasma is indicated after the third session of plasma exchange due to
Yes.
deficiency of clotting factor and
Yes, exactly.
fibrination factor in all diseases. And totally agree with you that that albumin can be used here due to the difference in pathology between HUS and TTP.
TTP
is mainly
No, but
the
Dr. Yasser, I don't allow me to disagree with you. It's not for all indications that we can use the fresh frozen plasma after the third session. No, fresh frozen plasma.
not the first. Definitely with the frequent
not
session.
after
usually after the third session, there is depletion of coagulation.
Fourth session.
If you are not using,
you
if you are
cannot
not using from the start, usually it becomes indicated after the third session, about the third session.
for all indications.
Part of the
the substitute you are to share substitute, you are to contain plasma in your substitute from
this is not what's actually in the literature. You can this is not
usually we combine plasma
unless it is one of the indications, the few indications, which is the TTP, HUS, alveolar hemorrhage, and some other very minimal.
It is not written in the protocol.
Yes,
whatever the frequency and the number of sessions, you have to do plasma. But it is clearly said that you have to check coagulation profile.
Yes.
And don't test the PT and PTT within 48 hours from the last session, as it will drop for the coagulation deficiency.
Yes,
but if you are going more sessions, you have to check fibrinogen, you have to check for coagulation profiling, and if you are requiring some of the part of substitution, unless hazardous, for example, sensitization, I cannot substitute fresh frozen plasma in patients with sensitization for transplant.
But I don't want the message to be disseminated that, because in many cases, what happens is people use fresh frozen plasma because it's less expensive. And this is not indicated. I want to emphasize very clearly that
sorry, Professor Salah.
The indications listed in
sorry,
the
Professor Salah. So you are again with the use of human albumin only for the replacement, not to include fresh frozen plasma at all,
unless it is within the few indications listed for fresh frozen plasma, as I mentioned, and Dr. Hisham mentioned. Other than this, we cannot. Yes.
This is a point of debate. So I don't think. I don't
think it's debatable in the guidelines. In the guidelines, it's very clear.
Sometimes we will, at a point of our exchange,
many do that, but it's not right. Many do that because of the expenses, not for scientific reason.
We are talking in two different points.
Factor, and how could you correct the coagulation factor deficiencies if you have by the session, by advance of the session? We'll use plasma, and this occurs usually after the third session. Usually,
it's a part of substitution when required. It is not full substitution by plasma,
We
I
cannot do it.
understand that. It is
No.
not recommended in any of the ASFA guidelines to use plasma after the 3rd or 4th session. It is not prescribed, but
Yes.
it's definitely required to check for coagulation profile and give part of plasma units to your protocol of albumin infusion if there is coagulation deficiency.
Yeah, but as you
What
can
I-
see, one of our colleagues here is asking that due to financial causes they do that. Actually, it's better not to be done. If you are going to give him plasma for a non-indicated case, just because of the for the sake of money, then don't do the procedure. So, you are making or doing a procedure with also still very expensive. It's not only about the replacement. The filter itself is expensive, and you will not benefit the patient. So if just money-wise, no. For replacement of some of the deficient factors, okay, I might agree, but this will not be as replacement, a full replacement. That might be just to
It shouldn't be. Yes, it shouldn't be because
Just
it's from
replace-
10
cannot be
to
a full
15
replacement. It cannot, for plasma cannot replace the whole plasma volume. It will be a big amount of plasma. Usually, if you do this, you will use a big amount of plasma. What I said is that usually coagulation factor part the depletion by the third session,
guidelines.
and usually plasma is to be needed by the third session. And this is what is
and this should be.
Yes, both are
Also
correct. Both are
Yeah.
correct. Yes,
we
it's
are to
saying
check,
that.
we are to check, and
But I cannot, say it as an indication. It's something very, specific, and it should be taken by.
It is not a substitution, it is a replacement. When I
Yeah.
give 2 units plasma for patients with
But for
coagulation,
educational purposes, let's
Yes.
stick for the guidelines.
it is just a replenish of coagulation, so I have to use 1 or 2 packs of plasma
And this
if
is
there is coagulation deficiency.
yes.
exactly.
And this is
Exactly.
a scope a bit, this should not be on the scope of, this should be a senior consultant scope to determine, not a common practice.
By laboratory
for me-
investigation for coagulation
For me,
profile.
I cannot exclude plasma from replacement at all. We need plasma. Of course, if we can check and use it when we detect coagulation factor deficiency, will be more than excellent. But plasma will be needed at a point for replacement for plasma exchange for replacement of coagulation factor.
It is a replacement, not a substitution. Just to cut short, when you are using plasma, it is a replacement of coagulation factors in case of coagulation deficiency with repeated plasma exchange, and in a small amount, 1 or 2 packs will be more than enough. While substitution, full substitution, we need around 10 to 12 donors.
Would be a very huge amount.
This is another scenario.
But a specific indication for full substitution, but is included in this replacement. A question about the use of IVIG. IVIG removed by the plasma. Is IVIG is removed by the plasma?
Definitely, definitely.
Yes, I know what he means by this question, because many ask this: how you give IVIG at the end of the session of the plasma exchange, while it will be removed by the coming session, because in desensitization protocols, for instance, we give IVIG in the after first 3 to 5 sessions, and then continue after that every other day sessions without IVIG. Well, there is a point of this, but that's why you give it after the session, and the IVIG half-life is very small, is very short, and they circulate and they bind with the antibodies, and then the next session come to remove the IVIG antibody, the IVIG antibody complex, and then you administer after the session to form another complex, etc. So there
It's a scavenger. You can mean it that
Yes.
it's a.
It is a scavenger, yes. Exactly.
just a scavenger.
Exactly. Yeah.
But the other hand is the monoclonal antibody like rituximab, refizumab, or wintuzumab. It's preferred to give it that. But be in mind and very cautiously, if you are treating hyperviscosity syndrome, you cannot give immunoglobulin like monoclonal antibody or rituximab because the viscosity will be higher with treatment. So it's a must to do after 2 or 3 sessions to give that to ensure that the viscosity had been dropped to the safe level.
Yes.
Yeah, and you illustrated a very important point, Professor Salah, that the drugs removal during plasma exchange. Plasma exchanges is for removal of big molecules. So most of the drugs, usually over the day, drugs will be removed. So better to delay or take your medications after the end of the session to avoid its removal by the session.
Yes.
But it depends on what's called the volume of distribution. For example,
Yes.
are giving pulse steroid or pulse cyclophosphamide or cyclosporins, Prograf, whatever, the volume of distribution, meaning that it's distributed all over the cells. So if you are going to do plasmapheresis in the morning and you are giving cyclosporin or cyclophosphamide on the afternoon, on the next day, the distribution of volume of such a drug will be distributed all over the body. So negligible removal, steroids included, cyclophosphamide, cyclosporin, so it's safe to give it even 1 day apart from the treatment cycles will not be removed.
Okay.
Yes.
Thank you for your illustration. And no more comments and no more questions are remaining. Let we end the session. Now, thank you.
Thank you so much.
Thank you.
Thank you so much.
Professor Salah, for
Pleasure
this
being with you all.
illustrative lecture regarding plasma exchange and for your response for all our questions in a very scientific way. Thank you, Professor Isam Said, for joining us today and with your great experience in the field of therapy. Thank you for all attendees for their active share and for Dr. Hazem Abu Shusha for being the coordinator of this meeting. Excuse me to close this meeting.
تصبحوا على خير.
ورحمة الله وبركاته.
مع السلامة.
Good night. Thank you.